Hi, I'm going to talk to you today about a multifaceted intervention designed to attenuate black-white treatment disparities in cancer. I don't have anything to disclose this morning. Let's look at the problem. Starting in the 1980s, you can see that problems in lung cancer treatment have been demonstrated for curable lung cancer. This happens in a lot of cancers, but we're gonna focus on the lung cancer model. And all these studies are controlled for age, comorbidities, and socioeconomic factors, yet the black-white disparity still exists. This starts way back to Bach's Sentinel study in 1999, and the last report was Wolf in 2019. In our study, published in JAMA in 2010, if you consider the tissue-confirmed cases of curable lung cancer only, you can see that the data almost perfectly mimic that of Bach in his Sentinel study in '99. We did our study prospectively, and what we discovered is that Black patients with two or more significant comorbid illnesses almost never went to surgery, whereas white patients still did. And so this suggests implicit bias in decision-making in gray areas. Also, Black patients who perceive poor communication with white physicians were much less apt to go to surgery. And finally, in this time of denial and anger and shock, Black patients who did not have a regular source of primary care often disappeared before adequate diagnosis and treatment took place. What are the solutions to all this? Well, we decided to have a discussion with the affected community. The Greensboro Health Disparities Collaborative was formed in 2003 at the behest of the community after the Institute of Medicine report on unequal treatment. And what the community analysis showed is that this isn't the problem of bad apples, this is a system problem. And their conclusion was that transparency in real time could conceivably affect treatment completion. Obviously, in all the administrative data studies that have been shown, 5-year-old data, the cat's out of the barn, and that's not going to affect treatment now. The other thing they suggested was accountability, that the cancer care teams needed to know, again, in real time, how they were doing with Black patients and how they were doing with white patients. And the third concept that they came up with was enhanced communication. And by that, they mean not just using more understandable language so people understand what's really going on, but the communication has to involve engagement and re-engagement. It just can't be a one-time deal. Well, what we did is we took these concepts and tried to operationalize them in cancer centers, and the results of that were published in Cancer Medicine in 2019. 5 cancer centers participated, and I want to point out specifically the University of Pittsburgh Hillman Cancer Center. And in all our studies, we try and use at least 1 or 2 cancer centers from the north so people don't say that this is just a southern thing. And as far as eligible early stage lung cancer patients go, we included almost everyone. So this really was a pragmatic study. And how did we translate the interventions into cancer center use? First of all, we created a real-time warning system. Since the HITECH Act in 2010, almost all cancer centers have electronic health records, and so there are digital data everywhere. And in this real-time warning system, what we programmed in is that a warning would come up if a patient missed an appointment. And if that happened, a navigator would engage and re-engage the patient and overcome the barriers to bring them back into care. But the other thing I showed you earlier is there is such a thing as clinical inertia in cancer care. And so we talked to clinicians and we programmed in anticipated milestones in diagnosis and treatment of lung cancer care. And so if a patient was keeping their appointments and one of these milestones were not met, a warning would come up, and the navigator or a physician champion would engage the clinical team and ask, did you really mean for this to happen? For accountability, we use classic quality improvement, audit, and feedback to the clinical teams, and we did it according to race. So again, they knew how their white patients were doing with treatment completion and how their Black patients were doing, and they were able to understand when there was a gap there. And the third part of the intervention was a specially trained navigator who was proactive in engaging these lung cancer patients. And this navigator was trained in particular barriers that affect the Black community, and they also underwent anti-racism training from the Racial Equity Institute. And again, these navigators would communicate to patients in a serial, proactive manner. In terms of the analysis, we had a retrospective control group, and even though these data haven't changed in 30 years, we had a concurrent control group, so no one would criticize us for leaving out any secular trends. And so we did within intervention group comparisons, and we also did between group comparisons between the intervention and the retrospective and concurrent groups. The results, well, first, the within group comparison for the retrospective group. And what I want to point out here is we use stereotactic radiation as equivalent to lung cancer surgery. So even with that caveat, there was a 9% difference in the raw data in completed treatment for white patients compared to Black patients. In a multivariate analysis that again was done using age, comorbidity, cancer stage, gender, and socioeconomic factors, the odds ratio for a Black patient to receive full treatment was 0.66, and this was statistically significant. When we did the within intervention group comparison, with the intervention, treatment was almost perfect, 95.1% for white patients and 96.5% for Black patients. And in the multivariate analysis, there was no statistical difference. With the between group comparison, we used the white retrospective group as the referent group, as that was the best treatment before the intervention. And as you can see, we confirmed the 0.66 odd ratio for the Black retrospective group, but the Black intervention group and the white intervention group both got statistically and clinically and much better treatment completion than the white retrospective group. So this multifaceted intervention helped everyone. And when we did the concurrent group comparison in the multivariate analysis, both the Black intervention group and the white intervention group got better care, better treatment completion. I only picture the odds ratio for the Black intervention group here. So what does this all mean? To remedy systematic institutional level racism, number one, You should work with affected communities to determine the appropriate barriers to conquer and the appropriate outcome measures. Number two, you must measure outcomes according to race or other disadvantaged group. Number three, apply the interventions in real time, and they need to include transparency, accountability, and excellent communication that is both clear and serial in nature. And as good quality improvement folks do, you need to measure again, iterate, and measure again, and make sure you get it right. Well, this conference section has to do with artificial intelligence. How does that fit into all this? Well, the question arises, who do you put into this real-time registry? If you only use the patients who show up at multidisciplinary thoracic oncology conference, then you're missing a great deal of the population that could be effective. So what about figuring out the abnormal CTs and the ED and with screening CTs? Well, the number of abnormalities would be overwhelming. So how do we combine specific CT findings with specific exposures in the community and geocoding to maybe come up with a system that identifies the most likely patients to turn out to have cancer to put into the registry? The second way that AI could be used is identifying patients that are most likely to benefit from comprehensive, proactive, racially sensitive navigation so you can hire the right amount of people. And then finally, fine-tuning the gray areas of comorbid illness to really understand who would be at the most risk for these treatments. So this intervention overcomes some of the racial barriers in the medical system, and it's a systematic intervention that overcomes some of the social determinants of health. Still, we need to consider the physiology of the experience of racism and cortisol dysfunction and epigenetics, but that's a talk for another day. Thanks for your attention.